Barney. Let me, got it. There we go. Can everyone see that okay?
Yes.
Yeah, brilliant. So yeah, I'm Sam Belfrage. I'm a PhD student at the University of Winchester, and I'm really grateful to have the opportunity to speak today at the PPI Coffee Morning, because I've got a few questions I would like to bring to you all, and I would just really value the opportunity for you to tell me or give me some ideas of things that maybe I haven't considered yet, or maybe some examples from other research that you think has been really good practice that I might be able to incorporate into mine. So from being from the University of Winchester, we don't have such a strong kind of embedded PPI message or way of working that maybe the researchers do from Southampton. So it's a little bit different, and I've kind of come at it in what I think is really important, but you might notice things and you think actually you're missing something there. So I'm really grateful to have this opportunity to be able to have those conversations. I want to just give you a little update about who I am and what my work was before becoming a PhD student, because I think it's quite relevant to the work I'm doing. So my background is in public health, and I spent 10 years working in the local authority public health team in Portsmouth. And it was mostly around children's wellbeing, so work around substance misuse, work around safer sexual health as well. I'm also a qualified secondary science teacher, and all of my work for like the last 20 years has been around children and young people, really. And my PhD is looking at the role that parents have in managing their child's health, specifically of 0 to 4-year-olds. And I'm a parent myself, and my daughter Betsy is 5. So I've only just kind of come out of this side of the area that I'm working in. I'm a funded PhD student. So this title that's on the screen was given to me. I applied to kind of carry out this PhD project. This is the title that was given to me a year ago. So I'm 1 year into the study, into my program, and I've got 2 years left. So the wording of this will change definitely, because I'm not 100% comfortable with how it's worded. So I've just left it as it is, and that was kind of my starting point. So the idea of the PhD is about developing and evaluating the feasibility of a community-based health literacy intervention to empower socially disadvantaged parents or carers of children aged 0 to 4 years to manage minor childhood illnesses and confidently navigate health services. So the motivation behind it was around, this was written as well before COVID, which I think is quite important. The motivation behind it was about reducing inappropriate GP appointments. So for common childhood illnesses that parents could self-manage at home, and also to reduce inappropriate ED visits when maybe the family have got a GP appointment booked, but they wanted to be seen by someone quicker. I'm living in Portsmouth, and my work will be, well, my research will be carried out probably in Portsmouth and Southampton, but there are some geographical kind of considerations, especially around attendance of ED, like the location of where the families are living. In Portsmouth, there's huge areas of deprivation very close to the hospital. So it'd be very easy for somebody to walk there, whereas going to the treatment centre is 6 miles away. So there's some kind of geography things that I want to consider as well in this project. Okay, so that's just a little introduction. I'll try and keep it short as well, because I do talk a lot. Health literacy, I don't know if it's a phrase that you've heard before. It was something that I learned on my master's programme, but it wasn't something that I'd really heard of from my time in public health. So this is the World Health Organization definition of it that I've included into my project. And it's the idea that health literacy is a concept about the ability for someone to access health information, but also understand it, to be able to appraise it, to look at the strengths of it, to be able to critique it, and also to use that information to actually apply it into the decisions that they're making around their health, which I'm not interested in their own health, I'm interested in the decisions that they're making for their child's health. Okay, so that's what I'm in, that's what the kind of core concept is for my project. And why is health literacy important? So this is just a little bit about some of the background literature that's already out there around health literacy. So inadequate health literacy or low levels of it. So there's ways to measure it. There's lots and lots of ways to measure health literacy. There's currently 217 tools to measure health literacy. So finding the right measure that is capturing what I want to capture is one of the difficulties. So these different studies have used different measures of health literacy, and they've also potentially used different definitions of what health literacy means as well. But we're saying that a lower level of health literacy or reduced or inadequate health literacy kind of shows itself in ineffective and decreased use in preventative services, poorer child health outcomes such as increased levels of obesity, poorer oral health, and increased use of emergency services. And there's in the literature already out there are a lot of community-based interventions for parents, but they're not telling us how effective they are. So there was no systematic review saying this is what makes an effective community-based intervention. And by community, I mean anything that's not inpatient. So I'm not looking at anything that's carried out in the ED department or to potentially any kind of inpatient facility. It's community-based, but community in the bigger sense. So I've included things like text messaging interventions, phone messaging interventions, websites, any kind of digital work, but also face-to-face and community interventions in terms of maybe something delivered by a health visitor, or one of them was delivered in an oral health fair. So community in the broadest sense, but I just mean not inpatient. So this, I'm just going to minimize you guys so I can see my slide. So this is, I know the title of today's talk was about talking about those different little studies that make up my PhD. So this is just to visually represent what it is. So study one was that systematic review about how effective are the community-based health literacy interventions aimed at parents. And in that systematic review, I didn't set an age limit of the children. So I didn't just look at 0 to 4, I looked at all the way up to 16. Study two, which is what I'm working on at the moment, is a validity testing of a parent health literacy questionnaire to measure health literacy. But it's a tool that's specifically for parents. So it's looking at parental health literacy, not just the health literacy levels of the parents, but actually how they're using those skills to look after their child's health and well-being. So that's the study that I'm on at the moment. My data collection actually closed yesterday. So I've carried out the cognitive interviews just to check that parents understood the questions that they were being asked. And cognitive interviewing gives me a chance to ask parents what they're thinking as they're answering those questions. So one of the questions is around, I have someone who can come with me to a healthcare appointment, and saying to so someone who, oh, Eric, did you have a question?
It's really the systematic review. People who have done the work that you are reviewing, where do they publish?
Lots and lots of different places. So I did a literature search of 6 different databases. It's global as well. So I looked globally, and I didn't set any date restrictions. So I went back as far as possible. It was just if they had included a measure of health literacy. So if they had included a pre-measure of health literacy before the intervention and a post-measure, then I was going to include it. So that literally all over global. I've included, there were 11 studies that I found out of screening 10,000 studies. So 11 that actually met the inclusion criteria that I wanted for that systematic review. And actually what I found is that because the studies were so different in the way that they measured health literacy, like the tool that they used and the type of health literacy, for example, nutritional health literacy that's really focusing on food, or oral health literacy that's purely focusing on oral health, I couldn't put them together. So the studies were too different for me to be able to have any meaningful conclusion. They showed promising results, but I still can't say how effective that they were. Yeah.
Thank you.
Thank you. Sorry, I had minimized you so I couldn't see you. So please feel free to interrupt me. I do not mind at all. Yeah, let me keep you guys here so I can hopefully see you. Yeah, so cognitive interviewing is about asking how they're getting that thought process and how are they answering that question. So, for example, someone responded to that and said, well, I don't have anybody to come with me, but I don't want them to, and I don't need them to. So, you know, the answer isn't that they don't, but potentially they did have someone, but they're telling me that they didn't want to and they didn't need to. So the cognitive interviewing helps me iron out those kinds of things. Is the question really asking the question in a suitable way to get the respondent to answer in the way that I'm expecting? So cognitive interviewing is a great technique to do that, to test questionnaires. And then the questionnaire has gone out to parents, again, not just of 0 to 4-year-olds, it's gone out to parents all the way up to children age 16 and under. And I've had 713 responses back. So yeah, I'm really, really happy with that. And my data analysis for this will start this month. Hasn't started yet because it only closed yesterday. So that's that study. Then study 3, this is really interesting. This is looking at the health literacy profiles of parents living in areas of high deprivation. So I'm using the indices of multiple deprivation. It's a measure that combines 7 different kind of measures of deprivation and puts them together to give me a score. So in Portsmouth in Southampton, we have certain wards that have much higher rates of deprivation and poverty than some of the other areas. So I use the indices of deprivation, multiple deprivation, to highlight those areas. That's where I'll be looking to profile the health literacy needs of those parents. And what I really like about this, the tool that I'll be using once it's validated, it highlights the strengths as well as the weaknesses. So it tells me what those parents are doing really well to manage their health literacy. Like maybe the parents are really good at getting the health information, but they're not so good at applying it. Or they're really good at getting it and understanding it, but they're not critiquing it. They're not looking to see, actually, is there anything in this that doesn't really fit my family or doesn't really fit my situation? So that tool doesn't just tell me the needs, it tells me the strengths as well, which I think is really important. And I can use that as an assets-based approach to health literacy. So making the most of people's strengths as well as strengthening some of the limitations or weaknesses that they might have. And being able to profile the health literacy needs of that community allows me then to write kind of like case studies. So in this, they're called vignettes, but it's basically a case study of the families or the parents living in that area with some of the examples of the challenges that they might face in relation to their health literacy. So it could be about getting a GP appointment, that their health literacy is actually really preventing them from getting the GP appointment that they need. They've tried to use e-consult, but actually they just don't have the literacy skills to be able to complete that online form. Or it could be about understanding the medication label that they've got. They're able to get to the pharmacy, they've been able to get some pain relief for their child, but actually the dosing is quite complicated, and knowing when to give it is they're just not managing that well. So it gives me some examples of practical things that these families or parents are having difficulties with. So that's study 3. I'll have these case studies ready to go from the data from the health literacy questionnaire, but also from some interviews as well. So there'll be qualitative data as well as quantitative data. And then the 4th bit, which is so exciting, is I get to take these case studies, these vignettes, to the frontline workers working with families in these areas of deprivation. So it might be health visitors, it could be GP, I mean, it depends who I can get involved, hopefully some GPs, health visitors, people working in the Sure Start centres, some of the charities that engage with families, such as Home Start. In Portsmouth, we have a great one called the Roberts Centre, which engages with and supports families experiencing homelessness. And we say, these are the types of issues these families are facing. What can you do to help this? What do you think you already do to help this? But what do you think you could do that would do even better to help this? So it could be about the way, like the language that's used in some of the documents to communicate to parents, like some of the letters that they write to parents. It could be pharmacists saying, we'll use a method such as teach back to check that the parents have understood the information that they've been given. It could be about GPs. There's another initiative called Ask Me 3, where parents or anyone is really supported to ask the GP questions about the condition that they're discussing and talking about. So the final bit is to help me see where the intervention could be and where it could go, like who are the appropriate people to be able to deliver it, but also where would the families find it appropriate and accessible, because I don't want to create something that everyone, you know, the professionals are like, yeah, this is exactly what it needs to be, but the parents don't agree to that, or the parents don't see that as a problem. So I really, really want it to be something that is appropriate for the parents and that they feel it's accessible. So along the bottom, I've written patient and public involvement. I think on my next slide, can I move on? I've kind of talked you through all my other slides, but so my public contributor, I do have somebody. So I was really lucky that I was able to get some funding from the ARC to be able to pay somebody to be my public contributor, because I felt it was really important. So although I've got qualitative research and I'm doing interviews and cognitive interviewing, I still wanted that feedback from a parent in the community to say, you know, am I understanding this information in the way that it's kind of been said to me? So I was really lucky that I managed to get additional funding for that. I have monthly contact with her. She's a volunteer for Home Start, which is brilliant because it means that I can go to the Home Start session that she volunteers at with parents. So I go there as a volunteer to give something back to her as well. And the time that she gives me, I'm able to pay her, but I'm also able to go to Home Start and volunteer and talk to parents there. She's been really vital in identifying the key stakeholder organisations for me, such as Home Start, because I didn't know she volunteered for Home Start to begin with. Someone put me in contact with her and said, oh, you know, Jane would be a great person. She's a mum to 2 children herself. She does a lot of community work with families. And then she told me all about Home Start. And I was like, actually, this is a brilliant organisation for me to be connected in with my project. She's helped me with the distribution of study 2, so making sure that the surveys had gone out to families, and she's also supported me in the recruitment for the interviews, for the cognitive interviews for that as well. So I only have one person, so that's one of the limitations and downsides, and one of the things that I wanted to speak about today. But she has been really vital to this project, and I'm so grateful to have her kind of supporting me on that. And these are some of the bits that I wanted to discuss with you today. The possibility of a PPI panel. Am I too late into my project already to embed one? Do I think it could still be beneficial as the project goes forwards? How would I recruit? I have a limited budget, so how would I kind of afford it and be able to get the most from it? The PPIE log and how to measure the impact. That was something that I'd seen and I've just started to use, and I was wondering other people's thoughts on that, or other ways to measure and collect the impact of my public contributions. Also thinking about how to use my public contributor in terms of dissemination. I don't really know what my question is, but it's something around the dissemination and coming to the end of my project and maybe making a bit of a plan for that, so that I don't get to the end and I haven't got a plan for dissemination. So interested to hear people's thoughts on that. And the title, like the word socially disadvantaged, I don't like, but I'm interested to hear other people's views on it. And one other thing that I haven't put on there is the word interview. Is one of a different worker from Home Start said to me, can you not say it's an interview? Can you call it something else for these discussions? And I said, oh, I'm not sure I'll get through ethics by calling it anything other than an interview, but I'm interested to hear if anyone else has heard of anything or if that has been a possibility. Barney, this is a little bit of self-promotion. So this is an aside. I mean, I can come back to this at the end. So I was really lucky, again, because I'm funded through the ARC, I had the opportunity to have a PPI mentor. I don't know if you guys know Lynn Laidlaw, but she was my PPI mentor when I first started. And we had some funding to work on a project that wasn't connected to my PhD. And I told Lynn my title, and we started discussing this idea of empowerment and what does empowerment actually mean, and can my research empower people? So we created a series of 6 episodes called Finding the Power in Empowerment, and it's talking to researchers and members of the public about what empowerment means to them and what we need to consider as researchers, and kind of going forward how we use the term empowerment, really. So little plug, you can find it online if you want to listen. Barney can send you the link. I think it's super interesting, so I like to just put that in there, and then a little thank you. So let me stop sharing and I can see everybody properly and can ask me any